So I'm here to give you an update on the SDP's healthcare plan. As you know, I'm working in a public sector institution, but this is entirely in my personal capacity as the chairman of the SDP, and I do not represent any of the institutions that I'm associated with. Interestingly enough, there are a number of MPs from the ruling party in the various institutions in Singapore anyway. The first point I'd like to make is that Singapore has had a very good healthcare for a very long time. In fact, people don't realize this, but in 1960, the World Health Organization from Manila, they sent a team to Singapore and Malaysia to study Singapore's healthcare system because Singapore had achieved very high standards of healthcare. That was a time when Singapore's health minister was, to date, Singapore's best ever health minister, Mr. Ahmad Ibrahim, who passed away, and he's remembered by a very long road in Jurong. But this was what he said in his speech to the World Health Organization team. He said, "The medical and health developments of Singapore call for some comment. Singapore has been free from major infectious diseases for over 10 years, except for a localized outbreak. Malaria has been non-existent, although nearly $2 million, and this is 1960, was spent for anti-malarial services." And his director of medical services said, "The medical services has now become predominantly, though not entirely, the responsibility of the government, with the mass of the population entitled to it without personal costs. The medical personnel are all salaried employees of the government. Most of the hospital facilities are governmental. All these are financed from general revenues. Private practice persists for a small upper income segment of the population, especially in the city area." So we had a single-payer healthcare system during the 1960s and 70s, and some people think that's the golden era of Singapore's growth and development. Unfortunately, in the 1980s, healthcare became viewed not so much as essential, but as a commodity, as something that had to be traded and something which could be seen as an industry for profit. Before 1984, like I said, there was a small private sector, and most of our healthcare was government funded. Many of you can remember the $1 OPD visit. You'd go to OPD, you pay $1. You go to the hospital, you pay $5 a day in the old Boyer block in SGA, CPF. Then in 1984, Medishield was introduced. 1 year later, the first restructured hospital. In 1990, they realized that was not enough, so they introduced Medishield. 1994, Medifund, because even Medisave and Medishield was not enough. 2015, before the last GE, the Pioneer Generation package, and at the same time an attempt was made to have some kind of universality with the Medishield Life. And then now, before the next GE, we get the Merdeka Generation package. And you ask yourself, why were all these changes put in? Were they put in because the old single-payer system was bad? And I would argue that that is not true. In fact, this is the Government of Singapore's blue paper on the National Health Plan, published in 1983. And they reviewed the healthcare system in Singapore. And at that time, remember, this is still the time of the $1 OPD and the $5 hospital stay. At that point in time, Singapore's infant mortality was actually lower than the UK and the US. So in 1981, with a single-payer healthcare system, Singapore had better health outcomes than the UK and the US, which at that time were much richer than we were. So I don't think it's true to argue that single-payer healthcare is going to result in worse quality of care for Singaporeans, because we know that in the past we were able to do it. So what is the effect of having this privatized, very commercialized healthcare? One of the major effects has been a rise in inequality. Now, inequality is something that people talk about. And we know people say, oh, you're talking about the politics of envy. Everybody wants to drive a Maserati or Ferrari or live in a bungalow. But we're not talking about luxuries here. What we're talking about here is life and death. We're talking about keeping yourself healthy and alive. And the statistics are pretty stunning. These were covered in the Straits Times last week. But from the National Registry of Births and Deaths, you can see the average age of death for a Malay Singaporean is fully 7 years younger than a Chinese Singaporean. Now this 7-year difference, in other words, an average Malay Singaporean dies at the age of 70 compared to an average Chinese Singaporean who dies at 77. And this is a striking difference. This is greater than the difference between black and white Americans in the United States, which we know is a very unequal society. And this difference occurs across all causes of death. It's not just due to eating too much oily nasi biryani and things like that. And in fact, there is data which shows that it's nothing to do with ethnicity, but it's more a function of economics. In fact, Professor Wong Tian Yin and Professor Tai Yi-Xiong and colleagues have shown that even within the Malay community, the high socioeconomic status Malays have a much better healthcare outcome compared to low socioeconomic status Malay. So that is a huge piece of evidence suggesting that in Singapore, the outcome in terms of life, death, complications of illness is a function of your socioeconomic status, which it should not be. It's not just socioeconomic status, very often it's language. And again, the same group, I've looked at diabetes and complications of diabetes, and they found that English-speaking Indians like myself have much fewer complications than Tamil-speaking Indians. And again, this same phenomenon has been seen in the Malay community as well. I'll be honest with you, when I'm on duty in the wards, sometimes I'm a little bit happier when I see a Malaysian houseman, because generally they can speak Malay, they can speak Mandarin, they can speak some dialects. Even the Indian Malaysian houseman from KL can speak some Cantonese. But their language is a key part of ensuring good outcomes. But whatever it is, your standard of health should not be a function of how wealthy you are, what your socioeconomic status is, or how fluent you are in the dominant language. Other reasons why the socioeconomic status influences health outcomes in Singapore is because of people avoiding screening and treatment. Now, this is, again, data from Professor Gerald Koh and his group looking at high blood pressure. Now, you know high blood pressure has no symptoms. You don't get any symptoms until your blood pressure is really, really high, and then you get headache or dizziness and things like that. But that's too late. You need to start treatment when your blood pressure is just about 150, 160, at a level in which it can be controlled and complications can be prevented. So Professor Koh and his team went into the rental flats in Taman Jurong, and they tried to investigate why people with high blood pressure were not being treated or they were not being diagnosed. And the major reasons that they found were people found it was too expensive to go and get screened, too expensive to get treated. So even if they were diagnosed, they were not screened, and neither were they treated. The same is true of cancer. Again, the same group in the Jurong West sort of area. And what they found was that screening for cancer, these are recommended screenings recommended by World Health Organization and also Singapore's Ministry of Health. The people living in the rental flats had a very low uptake of screening for cervical cancer, screening for breast cancer, screening for colon cancer. And the result of which, if you don't go for screening, if you don't go for early treatment, you end up with complications. Like I do rounds in general medicine, and it's very frustrating. We see old people who come in with a stroke, and they come in with a stroke, and invariably I ask them, have you ever been diagnosed with high blood pressure before? And they say, oh yeah, about 10 years ago, somebody told me I had high blood pressure. Did you take medication? No. Did you get treatment? No. Why? Oh, I had no time, I was too busy, it was too expensive, nobody could bring me to the clinic, I was working in 2 jobs. So these are the realities of what doctors in the public sector see day in, day out, and many of you have seen in your friends and relatives, people who do not go for essential primary care because of the cost or because of some other reason, and that results in complications. Because you can imagine, once you've had a stroke, the consequences are tremendous compared to somebody just taking a medication every day to prevent a stroke with high blood pressure. So these are some of the issues that we are dealing with. And unfortunately, Singapore is a bit behind other countries in this. In the developed countries, they have found that dementia rates have dropped significantly. And this is in the United States, which has a terrible healthcare system. It's got some really good healthcare, but it's very unequal. But in spite of that, the dementia rates in the United States from 2000 to 2012 have dropped by about 25%. And that's because of better control of diabetes, high blood pressure that's being rolled out in the community. In contrast, in Singapore, the NKF has commented that in 2012, they were seeing about 3 patients with kidney failure a day. 2019, the rate has increased to 5 a day, and they think it'll be 5.8 a day by next year. And these are pretty worrying figures, especially when you think about how a lot of this is preventable with good primary care, with screening, with management of your diabetes, management of your high blood pressure, and you end up with the most expensive treatment, which is treatment of complications, dialysis, treatment of stroke, and those things really affect your quality of life, and in fact, they even affect the extent of your life. So in 2012, the SDP decided we had to do something about it. As you know, we raised the issue in the 2011 general election, and there was certainly a lot of traction given to that. And so we had a public consultation. We launched the National Healthcare Plan in 2012. We had a panel. It was mainly doctors, but we also had a health economist. We had people from the private sector, as well as in the public sector, GPs, as well as specialists. And the key feature of the SDP healthcare plan is a single-payer universal healthcare system with a government-managed central healthcare fund. So this fund will be run along the lines of a government-subsidized public insurance scheme, and it will finance compulsory basic health, accidents, pregnancy coverage for all citizens and for PRs who are here more than 6 months in the year. So this is essentially a single-payer scheme. It's almost like going back to what we had before 1984. But the difference is it's insurance-based, so it's not entirely tax-based, because we don't think that the tax-based system is going to fly at this point in time. So what we propose is that we do away with Medisave, Medishield, and Medifund. They are too complicated, and there are too many gaps in the system. And in actual fact, Medishield, Medisave, and Medifund, they actually make up a very small proportion of total health expenditure. They have never made up more than 20% of total health expenditure. This is a paper from some time back published in the World Health Organization, and they pointed out that for Singapore's healthcare expenditure, government health expenditure accounted for about a quarter. Now it's gone up to about a third. Medisave, Medishield, and Medifund account for only about 10% of total health expenditure. The bulk of it comes from out-of-pocket expenses. That's you going to the GP, you pay cash, you pay nets, you pay PayLah, pay now, whatever. Or employee benefits. Like when I go and see the doctor, the university pays for me, I can make a claim. A lot of us, our healthcare is provided by our employer. You go and see your panel doctor from your company, you get admitted, you file a claim to your company. And that's the reality. So when healthcare inflation goes out of control, it doesn't just affect the individual, it affects the company, because they see their healthcare bill going up and up as they're paying for their employees. So that's a serious problem all around. So this is, again, data, historic data, 2002 to 2011. So the green is the government subsidies, which have been about 30%, 20 to 30%. This is Medishield, the red. Blue is Medisave. But the bulk is actually from employer-funded healthcare and out-of-pocket expenses, which is simply not sustainable. You cannot keep going on like that. Now, Singapore is not the only country with this kind of problem. The country which exemplifies this is the United States. So this is from the World Bank, and what you can do is you can put in the countries that you're interested in. So I put in Malaysia, Singapore, China, United States, India, UK, and Australia. And the United States spends twice as much on healthcare as any other country. UK and Australia are here. China, Singapore, Malaysia are somewhere down here. The United States spends a huge amount on healthcare. Hospitals in America are ridiculously expensive. But when you put in public expenditure as a percentage of total expenditure, the United States is way down over here. The UK is almost entirely government-funded healthcare. They have the National Health Service. It's inefficient, it's a bit slow, but it provides really high-quality care at zero cost. When my sister was here a few years ago, she broke her foot. She had surgery done in Singapore. She lives in the UK, so I flew back with her. We went to the NHS clinic. She saw a nurse. She didn't see a doctor because she didn't really need to see a doctor, but the nurse could have called the doctor if needed. She had the dressing done. It was pretty efficient. She waited for about 15, 20 minutes. And as I was walking out of the clinic with her, I asked her, so where do we pay the bill? And then she looked at me and the nurse overheard us and she sort of laughed. And she said, there's no way you pay the bill. She said, you live here. It's your right. As a PR or as a citizen in the UK, you have access to universal healthcare. So this is the UK. Now, we're not advocating something like that. Partly because culturally in Singapore, we have gone so far from that, we don't think it's going to be possible to come right back. The Australian system, on the other hand, is closer to what we have. where you've got a health insurance. There's a compulsory health insurance that everybody pays into. In addition, in Australia, if you're employed, you pay for a supplemental health insurance, and that is taken out of your wages. So they have, but they still have a significant government proportion in healthcare. So US, again, China, Singapore, Malaysia are way down over here. But the out-of-pocket payments are what hurts individuals. And in fact, the previous Director General of the World Health Organization put it this way. She said, direct out-of-pocket payments at the time of care are identified as the single biggest barrier to universal coverage. While user fees have been promoted as a way to reduce the overuse of services, this is not what happens. User fees punish the poor. They are inefficient. They encourage people to delay seeking care until a condition is far advanced and far more difficult or expensive to treat. And when people do pay out of pocket for care, financial ruin can be the result. So this is what we are saying. This has been a universal call. It's not just in Singapore, it's in many other parts of the world, that we really need a truly universal form of healthcare. So what we have right now is a very complicated healthcare financing system. There is this national health expenditure, which has been estimated as about $20 billion. The largest portion of this comes from government subvention. These are the subsidies provided to C-class B2 patients in public hospitals and to polyclinic patients. And employer benefits. That's your company doctor, that's your claim from your HR. But you've got other things such as Medishield, ElderShield, you've got Medisave, you've got cash, and you've got Medifund. And effectively, Medishield, Medisave is our own money that we put into these insurance schemes or medical savings accounts. So the government expenditure on healthcare is effectively about a third, and 2/3 of it is our own money or from our employers, which de facto is our own money as well. So if you go to the Ministry of Health website, you can get a breakdown on the actual figures, and you can see there's been a significant rise in healthcare spending. The Ministry of Health expenditure has gone from 5.8 billion to 7.5 billion to 8.2 billion, and in this year's budget, it's going to be 10-point-something billion dollars. So that is close to what we had actually asked for in 2012 in our original version of the National Healthcare Plan. But that is government expenditure. On the other hand, if you look at Medisave, now Medisave is our money. Every month we put in a certain percentage of our income, our employer puts in a certain percentage, and this is in $billion. Okay, we're not talking about $1 million here, we're talking about $1 billion. So the government is holding on to this Medisave fund balance, which is currently in 2017, $88.6 billion. The amount of money that Medisave spends every year is in $1 million. It's not in $1 billion. So that's 1/1000th of this amount, and it's $964 million. So effectively, every year, the Medisave fund is accumulating more and more money, and there's very little transparency or accountability as to what is happening with the money that's in the Medisave fund. So theoretically, if you take 6% of $88 billion, you're generating about $4 billion, which could be used to effectively account for half of the total government health expenditure, and way more than is actually spent at all. And that's just at a conservative 6% interest rate on the $88 billion that's sitting in the fund. So why is this the case? Professor William Hsiao from the Harvard School of Public Health was one of the early advisors to the Ministry of Health when they came out with Medisave and Medishield. And he's written an article in the Journal of Health Policy and Public Law, Health Public Policy and Law, and he has argued, Medisave was derived from the principles of self-reliance and self-responsibility, with the government ensuring access only to basic services. Translation: people's access to healthcare depends directly on their ability and willingness to pay. Since humans are endowed with unequal ability, given unequal social support or economic opportunity, it means that our incomes are vastly different. Thus, Singaporeans have unequal access to healthcare. This was a conscious decision made by the government in terms of trading off equity and efficiency. So if you study health economics, they tell you there's three things in health economics. There's excellence, there's equity, and there's efficiency. And you cannot have all three. So the healthcare system in the US has excellence, and it's got efficiency. It's very fast. You want a CT scan, you want an MRI, you get it done straight away, but you pay for it. So the result of which is there were 40 million uninsured in America before Obamacare. Now there are about 20 million. It may go back to about 30 million with Trump. In the UK, you've got excellence and equity, but you don't have efficiency. So the National Health Service, you've got very good care, but you've got to wait a long time. You want a hip replacement, sometimes you've got to wait 6 months or 9 months. So there's no efficiency in the UK health system. To translate it into Singaporean terms, you cannot be cheaper, better, and faster. You can be cheaper and better, that's like in the UK, but you cannot be faster. You can be better and faster, like in the US, but you cannot be cheaper. So it's just not possible to be cheaper, better, and faster. And even in public healthcare, there's significant inequalities which arise. And this was illustrated best in a column in the Straits Times by Professor Lee Wei Ling. This was when she was still given airspace in the Straits Times. And she talked about a friend of hers who had been admitted to one of the public sector hospitals for a head injury. And so she said, she asked her friend, who was the doctor looking after the patient? Her friend was in a subsidized ward, and her friend didn't know. So she said, write down my name and mobile number on a piece of paper and give it to the most senior doctor, ask him to call me. She said, the moment the doctor saw the note, he telephoned his head of department. My friend had never seen or heard of the head of department before that. Other doctors in the hospital asked my friend, who are you and how are you related to Professor Lee Wei Ling? An hour later, the head of department called me to give me the medical details, sounding as though he had been in charge all along. The next day, a bouquet of flowers from the hospital appeared in the room of my friend's husband. A senior doctor took care of my friend's husband and performed every operation on him personally. My friend's husband had been admitted as a subsidized patient because all emergency admissions are categorized as subsidized. So this is the problem. In the public healthcare system, because it's so overwhelmed, it's often very difficult to give individual and personalized care to individuals. And that's why people resort to dropping names like Professor Lee's friend. The other point is individual responsibility is important. Okay, we should look after our health. We should look after our diet. We should look after our exercise. But in reality, there are some individuals who are going to get sick regardless of what they do. And this was very poignantly told in the Straits Times by one of the journalists who talked about her child, a little boy who was born with a rare genetic disease because both parents were carriers of the disease. So it's a genetic disease. None of us can choose our genes. You know, we think we can, but we cannot. Okay, you cannot choose your parents. You cannot choose how you are born. And this poor child was born with this genetic disease, which required a medication that cost $10,000 a month. Okay, and you know, who in Singapore can afford to pay $10,000 a month for medication for their child? So she did some searching around. She's a very educated individual. She found that she could get it for $5,000 a month in Australia. So she actually had someone fly to Melbourne, buy a batch of the $5,000 a month medication directly from the Australian firm and fly it back. So that's the kind of situation that we're dealing with. These individuals who have uncommon diseases which are way beyond the cap that is provided by even Medishield Life. And the result of that is that there are individuals in Singapore who are in severe hardship because of medical costs. This was published in the Straits Times again, where they looked at Singaporeans who were counseled by Credit Counselling Singapore over the years. And as you can see, there's been a rising number of Singaporeans counseled by Credit Counselling Singapore. And the major reasons for their being in debt, overspending, job-related, and medical, which is pretty striking. 21% of Singaporeans and 36% of PRs in 2010 had to severe financial problems because of medical reasons. This is among those who were counseled by Credit Counselling Singapore. So it's actually increasing over job insecurity as a cause of financial difficulty in people living in Singapore. And we believe that no one should have to go bankrupt because of healthcare. We don't want to have a situation where people are so desperate that they're being forced to go to loan sharks just to pay off their medical bills. Now, theoretically, Medishield Life was set up to provide catastrophic health insurance for people who have diseases which their Medisave cannot cover. But if you look at the Medishield Life fund, they have a very unusual way of calculating their incurred loss ratio. Normally, for an insurance company, my understanding is they look at how much they collected in premiums and how much they paid out, and that constitutes the loss ratio. For Medishield Life, though, they look at their premiums collected, and then they make this worst-case scenario that everybody is going to get sick and die and won't be able to pay premiums, and then they have to go and pay out the balance. So as a result of which, in 2017, Medishield Life collected $1.9 billion in premiums, but they only paid out $836 million in claims. So if you look at it, this is a loss ratio of about 50%, but the way they calculate it is a loss ratio of 96%. Now, to give you some perspective, under Obamacare, insurance companies are not allowed to carry a loss ratio that's below 90%. So this is, if you use the same calculation that they use in Obamacare, this would be a loss ratio of 50%, which would be illegal under Obamacare. But again, this is the nature of the current government, is to be kiasu. So they believe that they have to plan for the worst possible case scenario. They build this umbrella that protects you for things that will never ever happen, or because they say they're just being prudent and cautious. And again, as Juris pointed out, Medishield Life is so inadequate because of all of these restrictions. There's a very high deductible. The first $3,000 you have to pay yourself, either in cash or in Medisave. There's also a daily cap on how much you can claim from your Medishield Life, even though it has made an advance in that it covers pre-existing conditions. So the third M is Medifund. Now Medifund is the safety net. So those who are homeless, so I've got homeless patients, they get access to Medifund, they get 100% coverage, but it's only for 3 months or 6 months duration. This is an example from one of my patients. But in order to have Medifund, you must exhaust yourself and your immediate family members' Medisave accounts. And this is what we argue, that the PAP's Medisave healthcare financing system is actually placing the burden on the next generation. So this is an intergenerational transfer of funding responsibility that we think is wrong. You know, young people in Singapore are struggling to find the funds to bring up their kids. If they have to pay for their parents' healthcare as well, it imposes an intolerable burden on them. So this is what the PAP always claims that they're not doing, which is passing the buck to the next generation to pay for this generation's illness. But that is essentially what they are doing by expecting individuals to depend on their family members to pay for their Medisave or their Medishield Life premiums. So what do we want instead? What we want is a single-payer government-run insurance system with an affordable premium. So basically the idea is if you get sick, you should concentrate on getting better. You shouldn't worry about who's going to pay your bills, whether you're going to have to sell your house to pay your debts. And this is why I tell my patients, the priority, don't worry about the insurance, we'll settle that later, don't worry about that. Your goal is to get better so you can go back to your family, you can be a part of your life and your family life as a whole. So the principles are, we want universal, affordable healthcare coverage to be provided to all Singaporeans. We want an increase in government spending on infrastructure and human resources. And we think we can claim some credit that a lot of that has been done. In 2012, the government health expenditure was only $4.5 billion. In this year's budget, it's $10.5 billion. So it's more than double. Of course, some of that is from building very fancy hospitals that look a bit like country clubs. But there has been, to their credit, significant increase in expenditure. The other parts have not been followed up as yet. In particular, we think there needs to be a sustainable system to contain rising healthcare costs by tightening medical audit. Now, by tightening medical audit, we do not mean going after well-meaning doctors who are trying to help their patients and prosecuting them. But what we mean is ensuring that what is paid for is done, that healthcare procedures are done according to guidelines and not according to profit-centered motive. So this is what the World Health Organization calls universal health coverage. So the World Health Organization is working around the world so that all people and communities receive the quality services they need and are protected from health threats without suffering financial hardship. So essentially that's it. See, if you get sick, it should not mean that you have to worry about whether you're going to have to suspend your child's education or whether you're going to have to cut back on having dinner with your family or things like that. These things should not be the case in a civilized, high-income society. So what are the key features? Originally, we thought we needed a significantly larger government contribution, but for a variety of reasons, the government contribution is actually caught up with what we had forecast in the 2012 paper. Overall, we think there should be a slightly larger government contribution, and as I pointed out, just simply tapping on the Medisave fund balance, it's easily going to be more than enough to cover that. And this would be closer to developed East Asian norms in Korea and Taiwan and Hong Kong. We want a single-payer public insurance system. We want evidence-based regulation of insurance payouts. Right now, the insurance companies, they often have absolute power over what is paid out. So if you can get through the system, you know, the institution can charge what they want and the insurance companies will pay. We do call for co-payment, and part of the reason is that there should be a certain sense of ownership. Because when you give somebody something as a charity, as a handout, you tend to put down the individual. Whereas if the individual is paying something, even if it's $10, there is a certain sense of ownership and pride that this is something that I am contributing to my own well-being and recovery, but it should not be a hardship. The other difference is that we are asking for caps, and their caps are caps on what the individual should pay. We're not talking about caps on what the insurance pays out. So you know the Straits Times reporter whose child has to pay $10,000 a month for medication. There is a cap. See, Medishield Life has a cap, an annual cap, it's about $100,000, and they have a lifetime issue. So we want to argue that the cap should not be based on what the cost of the treatment is, but rather should be based on what the individual should be able to afford to pay. So as an example, these figures are, again, the 2012 figures. We don't think they need to be adjusted very much, but essentially the contribution will average around $50 for the average Singaporean. For those who have no income, the contribution will be heavily subsidized. And this is very close to the Medisave and the Medishield Life premiums that we are paying right now. The key element of this, though, is that it's a simple plan. There's only one system. There's no more Medisave, Medishield, CareShield, ElderShield, you know, what do you call it? CHAS Blue, CHAS Orange. You know, you really need a dictionary to try and understand the current healthcare schemes in Singapore. So it's just a single scheme. Once you have paid your contribution, you get a healthcare benefits card. And this card can be used everywhere. It can be used in the polyclinics, it can be used in GP clinics, and it entitles you to a 90% subsidy on the majority of your healthcare spending. For acute illness, it's slightly different. You're going to see the GP, you pay a bit more because the amount is relatively smaller. Now, like I said, in contrast, the system that we have is very complicated. In fact, this Merdeka generation package is so complicated, they have to send 50,000 people out knocking on doors to explain to people what it's all about. They even have to spend thousands of dollars producing this music video with Dick Lee to explain what a Merdeka generation is all about. So what we are talking about is something that's a lot simpler than that. Okay, just simple. You pay one premium, you get one card that gives you a fixed subsidy rate. So I'll give you an example. If you go to the CPF Board website, they give you an example of somebody who has a heart attack and needs a balloon angioplasty. So they say you're 50 years old, you stay in a C-class ward, your claimable amount is $8,000. You pay the deductible of $1,000, and then they calculate your co-insurance in this crazy way, 20% of $2,000, 15% of the next $2,000, and so on and so forth. So effectively, this is again lifted off the CPF website. You pay an excess of claimable amount plus deductible plus co-insurance, and it comes up using the 90th percentile to about $4,000. Post-discharge, so you know it's not just the hospitalization. You've got to go for your follow-up, right? You had your balloon angioplasty, you need to see the cardiologist, make sure the thing doesn't get clogged up again. You need some medication to keep the stent open. All these payments are paid in cash because you cannot use Medisave for outpatient treatment of heart disease. You can use Medisave for dialysis, for chemotherapy, for certain things. You cannot use it for treatment of heart disease. Hopefully you get no readmissions. On a conservative estimate, you're paying $200 to $400 a month. So at the end of 6 months, your total cash outlay is closer to $6,400. Now under our plan, okay, you get chest pain, you go to A&E, you get hospitalized, you pay about 10% of the cost. Using the same estimate of the cost, just one figure, okay, 10% of $12,000 comes out to about $1,200. There's a cap on the cost of the outpatient visit, there's $20 to $40. The total cost per year is $1,680 for the angioplasty, for the hospitalization stay, and for the visit. If you are low income, this is capped at $500 per year. One card, one policy. So effectively, it cuts out a lot of the bureaucracy, it cuts out a lot of the paperwork, and you know, the hospitals now have hundreds, if not thousands of administrative staff. In the old days, SGH used to have one matron, one supervisor. Okay, those days are over. You know, now they have hundreds of staff at multiple levels doing billing, doing administration, doing coding, doing all kinds of things. You know, and it's just a bureaucracy that feeds on itself and adds incredibly to the cost of healthcare. So we also believe in a regulatory framework. We believe that effective drugs, those on the World Health Organization essential drug list, should be on the national formulary. We should promote local generic drug manufacturers. Some of this is happening. We should go back to the Singapore Medical Association guideline on fees, and there should be a single-class wards in public hospitals. There should be elimination of the hotel services. We've got a very good private sector of healthcare in Singapore. There's no reason why they need to compete with the government restructured hospitals. They can have all the medical tourists they want. You know, medical tourists want to come to Singapore to have good healthcare, that's fine. They can go to Raffles, they can go to Parkway, they can go to Farrer Park. We also believe in a health benefits smart card. Now the difference here between us and the current system is we have this currently, some of you are aware of the National Electronic Health Record, which is kept in a central repository. And as you know, there have been numerous data breaches. There was the HIV data breach, there was the SingHealth data breach, and the trouble is that individuals have no access to the National Electronic Health Record. What we are proposing is that you control the access. You have this smart card, and this smart card has all the information about your healthcare. Now, to be honest with you, this is not entirely original. In Taiwan, this is what they have, because people move from Taipei to different parts of the island. And so they have their own record with them. So if you go and see a GP, you can choose to give the GP what information you want to give the GP. So essentially, the control goes back to the patient. It's not controlled centrally. And this smart card can have information on your payment, utilization history, important medical information, as well as the current medication you're on. So again, we believe in strengthening health technology assessment. We will only accept treatments which are proven to be effective and worthwhile. So how is this going to happen? Now, 80% of the healthcare in Singapore is provided by GPs, the primary healthcare. You know that. You go to every HDB block, there's a GP downstairs. Okay, and a lot of the GPs are doing really important, critical work. But again, you know what Singapore is like. You go to a hawker center, one stall has got a long queue, the other stall has got nobody standing outside there. So some GP clinics are really busy and others are not. So a lot of the GPs, unfortunately, are struggling. Okay, and some of them are resorting to things which shouldn't be done, like selling cough mixture and stuff like that. So we believe that all of these individuals are well trained. We have some of the best medical schools in the world. And they are individuals who believe in looking after people. That's what they were trained to do. And that's why they set up clinics in the heartlands. And so we want to strengthen primary care. So there will be a 10% co-payment for all hospitalization, drugs, investigations, and surgeries, except for these acute GP visits. You get a cough and cold, you go and see the GP. We think there should be a fixed subsidy of $10. You want to pay more, you pay more. The GP wants to charge you only the $10, that is also fine. Now, the interesting thing is this is very similar to the CHAS system, which came on after we came up with our National Healthcare Plan. However, the CHAS system is very complicated. There's an orange, there's a blue, there's a pioneer generation, now there's a Merdeka generation, and they've got all kinds of different ways of calculating how much you get. The CHAS system also is not a full subsidy, so you've seen, some of you have been to your GPs and used your CHAS card. You know, I took a relative to see the GP. Previously, she used to pay about $50. Now he said, oh, you can use your Pioneer Generation card. You only have to pay $30, but my fees have gone up to $60. So essentially, you know, if you do not have a simple system that is easily reproducible and hard to game, you're open to all kinds of different ways these things can occur. So under the co-payment system, there will be a $10 for acute self-limiting illnesses, your cough and cold or your sprained ankle or whatever it is. Everything else, it's 10% of the bill. The other thing that we feel is important is engaging the whole of the healthcare sector. Now, Singapore has a lot of really good nurses, but a lot of them are not doing nursing. Okay, a lot of them end up being property agents and things like that, which is really, really sad. You know, and it's partly because of the conditions of work in the public hospitals. And so you see, but many of these well-trained nurses are living in these housing estates. And so what we proposed during the last election, actually one election ago, was the idea of void deck nurse-run healthcare centers. You know, to get a private nurse in Singapore is horrendously expensive. You pay $200 for a staff nurse, or you pay $180 for an assistant nurse, and that's just for a 12-hour shift. And most people cannot afford to pay that. On the other hand, if you had a primary care-centric service based on the GP who's downstairs in the block, with a nurse who's covering maybe 2 or 3 blocks, they could cover the healthcare costs for the individuals, elderly or disabled, living in that block at a much lower cost than the cost of trying to bring somebody to a fancy-looking healthcare center or community hospital. So this, again, philosophically, you're bringing healthcare back to the people. You're empowering the individuals. You're empowering the Singaporean doctors and nurses who are essentially the backbone of our healthcare system. Just yesterday, some of you may have read this in the Straits Times. There was a rather unusual headline in the Straits Times, but if you actually read the article itself, this was a study done by the Duke NUS Medical School. And they pointed out that currently only 30% of Singaporean seniors can meet their household expenses. And this is a rather shocking statistic. The researcher pointed out, though, that he was trying to explore the reasons why this happened. And he argued that this was due to an increase in the general cost of living and a rise in healthcare expenses amongst the oldest, the 80 years and above age group, which had the highest proportion of income inadequacy. He did put a caveat there. He said the introduction of healthcare-related cost mitigation initiatives, such as the Pioneer Generation and Merdeka Generation, might exist, but their downstream benefits and changes in the financial burden of healthcare costs need to be studied in further detail. Again, my point is, if you want to help people, don't put on this really complicated and bureaucratic scheme. Just have something simple and effective, like what we are proposing. The other thing about the current scheme is it's very hospital-centric. So, you can get a subsidy in hospital based on your income. But if you want to get transferred to a nursing home or a long-term care facility, they look at your household income. So most of these elderly people pass the means test in hospital, but they want to get discharged, they fail the means test because they've got somebody who's got relatively high income in the family. And the result of which is you've got differential subsidies. And this was highlighted at the end of last month, where there was this lady who had to pay a $19,000 deposit from being transferred from Singapore General Hospital to Sengkang Community Hospital. And again, who has $19,000 spare cash deposit to pay just to get transferred from a hospital to a step-down care facility? The result of which is the hospitals are way overcrowded because individuals who could go to a step-down care facility are not going to be willing to pay $19,000 deposits like this poor lady was being asked to do so. So there's a natural result, which is the overcrowding. People go to, anybody who's gone to a public hospital in Singapore will know. You go to A&E, you're prepared to wait 5 or 6 hours. And after that, you've got to wait even longer if you need a bed to be admitted. So we have argued that it's far better to age in place. Now, the government has given a lot of lip service to this term aging in place. But if you really want to age in place, you have to make it possible for people to access services at their home at an affordable rate. And that's how we think a void deck nurse-run healthcare service is all about. Furthermore, our system is also going to provide subsidies for the long-term care. There are some who cannot stay at home. Okay, you're all alone at home, you live in a place, there's a lot of steps, there's things like that. It's just not possible, or you're too disabled. We need too intensive nursing care. So there are some individuals like that. Although we believe that if you strengthen primary care, like in every developed country right now, you're going to reduce the incidence of complications, you're going to reduce the number of people getting strokes, getting all these complications. But if you do end up with one of those complications, then our system is also going to cover long-term care. So there's a cap in terms of how much you pay. The first year of treatment, you pay about $2,000 in cap. The second year of treatment, and it diminishes over time. If you are low income, the amount that you pay is also correspondingly reduced. And again, there's a 10% co-payment. So coming back to this, how are we going to fund this? We estimated in 2012 that this would cost about $10.5 billion. Interestingly enough, that is about the same figure that's currently being spent on healthcare by the government right now. If you take into account medical inflation, and if you balance out some of the evidence-based control measures that we're going to put in, we estimate it may take about between $12 and $13 billion. Now, there's a straightforward source of the extra $3 or $4 billion. Like I said, the government Medisave fund is sitting on $88 billion. At a conservative return of 6% on that, you're talking about $4.8 billion, which is available right away to make up the shortfall, to go from this complicated scheme that we have right now to a simple, single-payer, universal health insurance scheme. So this is what we're talking about. The key features of the scheme: larger government contribution, public insurance, evidence-based regulation, co-payments with caps on what you have to pay, not caps on what you are entitled to in terms of essential treatment for your illness, and also responsive long-term care at the point of need. So if you want to stay at home, you want to be looked after in your home, you want to have somebody to come and help you do certain activities of daily living, we think that is ideal and it should be supported. And it should be supported not by some complex bureaucracy, but by the nurse who lives downstairs. You know, she should be able to be compensated so she can do it within her time. She's got her own kids, she sends her kids to school, she goes upstairs, looks after the auntie or the machi upstairs, and then she comes back down and she gets paid for doing a service that is essential. And that's a win-win-win situation for all concerned. Instead of which the machi ends up getting admitted in hospital, gets stuck there, cannot get transferred to a nursing home. And it's just a system which frustrates everyone. So the question is, so you've got this very nice plan, okay, it looks very good on paper. How are you going to do it? You're not going to take over the government, okay, much as we would like to, we can't. Okay, and we'll be honest and we'll admit that. At the most, we'll win one or two SMCs or GRCs in the next election. So what we promise you is that even if we have only one or two GRCs or SMCs in the next parliament, you can be sure that our elected SDP members of parliament will hold the government accountable for how Singapore's health is protected. We will demand transparency in the actuarial calculations. This is what I mean about the funds, you know, the $1.8 billion in the Medishield Life Fund and how they calculate that they need 90% of that. I mean, that is beyond understanding. I've spoken to experts in the field and they say there is no transparency in terms of the actuarial calculations. We will also demand accountability for the spending markups and cost recovery that take place in public hospitals and healthcare facilities. We insist on expansion and implementation of the guideline on fees, and we want guidelines not just in how much the doctors charge, but how much the institutions charge. I think you remember some time ago there was a story about KK Hospital when there was a woman who was charged $40 just to have a nurse watch her take a shower to make sure she didn't fall. I mean, that's ridiculous. And so we want detailed accounts and justifications for the non-medical charges, in addition to the medical charges, which are going to be regulated by the revised guidelines. And you can be certain that the SDP will not allow the government to treat the health of Singaporeans as a commodity for profit-making, but rather as a fundamental right to be preserved and protected. And we can do that even with a small number of members of parliament. We can raise questions, we can call for divisions, we can call for amendments. And it falls down to a question of values. Because we believe that healthcare is a basic human right. Okay? Nobody chooses to get sick. Okay? There's this crazy idea, which was started by some right-wing American health economist, that there's some kind of buffet syndrome. Okay? That people decide if you give people free healthcare, they will choose to get cancer, heart disease, or herpes, or something like that. And I mean, that's ridiculous. You see, nobody in their right mind chooses to get sick. See, people who get sick, they want to get better. I see my patients in hospital, they say, oh, thank you very much, doc. I hope I get better, and I hope I don't see you in hospital, but I see you somewhere else. You know, because a hospital is a very unpleasant place. Okay? It's a place where people are sick, where people are dying. People just want to get out of there. So the question is, what do we do about financing it? And I'd like to end with this argument that was made by Jeremy Lim in an article in March 2017. And he has written, he said, in health, there will always be scarcity and difficult rationing choices, no matter how politically unpalatable such issues are. Singapore has enacted measures both in form and in function to balance the tensions between economic rationality and well-meaning social activism. In closing, it is worthwhile to recall American economist Thomas Sowell's quip, the first lesson of economics is scarcity. There's never enough of anything to fully satisfy all who want it. The first lesson of politics is to disregard the first lesson of economics. Whether Singapore's model continues to be financially sustainable will depend on the fine balance between managing the economics and the politics. And again, this quote has been around for a long time in the United States. And he says, it's a great day when our schools will have all the money they need and our Air Force has to have a charity bake sale to buy a bomber. And that reflects the values that are currently in existence in the United States and unfortunately in the current administration, where the military gets what they want, the banks get what they want, but the schools and the hospitals have to struggle. And the person who summed it up best, again, is Dr. Bill Xiao from Harvard School, where he talked about, he said, before you set up a healthcare system for any country, you have to know that country's basic ethical values. The first question is, do your people in your country have a right to healthcare? If the people believe that medical care is a basic right, you design a system which means that anybody who is sick can see a doctor. If society considers medical care to be an economic commodity, then you set up a system that distributes healthcare pretty much based on the ability to pay, and the poor are left out. So this is a question of values. You know, as we heard at the campaign launch, the SDP believes in people above profits. See? And that is what this healthcare plan is all about. We're going to take some questions. I'm going to hand the time back to Juris, and thank you all very much for your time.